I think we've heard obviously a lot today about how complex the world of CHC is. Everyone in this room knows that CHC isn't a 10-minute GP appointment, it's a multi-stage, multi-clinician process with hundreds of pages of evidence and decisions that change lives. But yet most of the AVT, so ambient voice technology tools that exist in healthcare were built primarily for that 10-minute meeting. And this session today, we wanted to bring to life the story of what happened when we stopped trying to adapt one of those tech tools for the world of CHC, and instead built something that was purpose-made for the world of CHC. So we'll be talking, we're kind of taking you on a journey from a product that broke repeatedly under the weight of real CHC workflows, to hours saved per DST and a way of measuring impact developed by Hampshire and Wight ICB that's now getting national attention. So I'm Theo from Beam. I'm joined by Marta from Hampshire and Wight ICB and Matilda Crowfoot, who leads healthcare at Beam. I'm going to be doing this as a bit of a fireside chat, so you won't actually hear very much from me. Cool. So to kick us off, Matilda, I'll come to you just for a bit of sort of scene setting. Beam isn't, I guess, a typical health tech company, and CHC is in some ways an unusual place to start within healthcare. So can you tell us a bit more about sort of how did Beam end up here?
Yeah, sure. Hi everyone, morning. Apologies for the tech issues at the beginning. So Beam didn't start as a healthcare technology company. We actually started as a social enterprise delivering frontline services about 10 years ago. And we were delivering services to support very vulnerable people. So people experiencing homelessness, people ex-prisoners, people seeking refugee services and asylum seeking services. And our tools really came out of those complex environments. So our first tool, at the time, it was called Magic Notes, and I've had quite a lot of feedback today on the fact that we shouldn't have rebranded, but I appreciate the feedback nonetheless. And I want to flag that the reason we built this tool was because our teams at the time were spending a huge amount of time reconstructing critical information off the back of very complex meetings. And our goal at the time was simple. It was really just to close the gap between that very sensitive conversation happening and a practitioner being able to write that information up. So at the time, we were very focused on where, it's still not working, where most conversations around AI in healthcare are focused on today. And that is really around speeding up the note via AVT. As we deployed much more widely, and if you could see the lovely logos on the screen right now, you'd know that we're working with about 300 frontline organisations in the UK today. But what we learned from that is that speeding up the note matters and it is important and we must get that right. But if we are going to support these really complex documentation workflows, we have to look at every stage of that journey because it is that which makes an impact on patient care. So to go back to your question, why do we start here? I suppose one element is that we are drawn to complexity ourselves. We always have been. Two, we had a very, when we first started deploying our technology, specifically Magic Notes, we started in local government in social care. And we're now working with 150 local authorities in the UK. So we've all heard today the intersection between local government and ICB. And so it was a natural step for us to start working with healthcare partners. And finally, and probably a really important thing to call out, is that we found a partner who was willing to be bold and brave and build with us. And that's Marta and Hampshire and Isle of Wight ICB. And Marta's going to share a little bit more about that today. But I want to be really clear, the technology wouldn't be where it is today were it not for partners like Hampshire and Isle of Wight ICB.
Perfect, thanks so much, Matilda. And I guess, Marta, maybe could you take us back to the start of the partnership between Beam and Hampshire and Isle of Wight? What was the CHC service actually experiencing? What made you look for a tool like this? And what made you decide to work with Beam?
So I'm sure it sounds familiar for everyone. The huge pressure, the ever-growing waiting list, frustrated staff who was stressed, who was exhausted, and we just couldn't keep up with it. So our DST at the time were taking days or even hours for preparation because of the complexity of the process. It wasn't about the people who were doing it. It was just the process which wasn't working. So the problem was real, and we knew we needed to fix it, but we were looking for the solution how we can do it. And when we start looking for the solutions, there were a lot of tools available on the market providing ambient scribing, but at the time, no one else had AI-enabled reporting. So we start looking for someone who was already embedded into NHS ecosystem and could provide for us the governance and the safety of this requirements, but at the same someone who was willing to work with us and develop something bespoke for our needs.
And what was it like, I guess, just you're not clinician, you're not necessarily digital, but did you feel like you had to drive a lot of this forward yourself?
I think it was always much bigger program. It wasn't ever about implementing technology. So this was about frustration from clinicians, which grow over things being so complex and not being able to keep up with the demand. But it was always about changing the culture and making sure that we embed it into our workflows.
Amazing. Want to move towards the pilots. Obviously, we piloted the tool in virtual ICB within Teen Healthcare. I think it'd be easy to just like show you some really nice headline stats that paint the picture of everything going really smoothly. That's not the reality of how the pilot actually sort of went. So how did it go in sort of your perspective?
I will be honest, because I am hoping this is a safe space. When we first put the tool against the CHC kind of workflow process, the results were pretty mixed, if I'm being really honest. So there were elements that worked incredibly well. So recording the MDT discussions, we'd co-built a very nuanced template to capture those conversations really well, and that was working so well, and it was saving a huge amount of time very, very quickly. What wasn't working so well was the kind of pre-MDT evidence gathering stage, where you've got to pull together reams and reams of information, often 500, 600, 700 pages from care plans. And it was breaking, quite frankly. It was jamming our technology. The images that were there meant that it wasn't processing consistently every time. Sometimes it was working, but it wasn't working consistently. But I think what was really interesting about that is that despite the fact it wasn't consistently working, clinicians were coming back time and time again. Clinicians who were initially quite skeptical of the tool, and I think Marta will speak a little bit more to this, would come back because of the impact in terms of the time saving, the quality of the assessments, the kind of impact on their work-life balance and well-being was so great that they were coming back to a tool which wasn't quite ready. In the pilot itself, we had a relatively short pilot, and so during that, we weren't able to implement the necessary long-term fixes that we needed. We did some hacky workarounds. We asked clinicians to split their giant documents into smaller documents. What was interesting in that process was that the process of using a PDF splitter was significantly more complex than using our technology, which I do think speaks volumes. And we had daily feedback loops, so it was very intense. Marta was at the centre of it. Our engineering team worked very closely with her. And we implemented that, and that in itself meant that clinicians were able to use the functionality. It wasn't perfect, but it was enough to have an impact at that point. But I think Marta will do the best job of really saying what it was like from a clinician perspective and that journey of piloting with them.
Yeah, so it was interesting and it was frustrating at the beginning, and because it simply at times didn't work. But I think it was really interesting because clinicians understood what we are trying to achieve, and they really engaged. They were coming back and with their feedback, with their ideas, and suggesting how we can solve those problems. And it was a really short period of time. At the beginning of the pilot, when we surveyed them, they were like, oh God, it isn't working, it takes more time, why you are asking us to do it? And only 8 weeks later, I had conversation with them and said, like, well, we might need to pause a little bit because we need to decide what we are doing next. And they all came back and said, like, please do not take it away because we can't imagine going back to the old ways. So this was our definite sign that we need to continue this work because it definitely made a change.
When it comes to the impact of the pilot, Marta, can you talk us through a little bit about how you measured impact to see so whether it's actually working and what you found?
Yeah, so from the beginning, we put really strict control over measuring the impact of the tool. We established the baseline for DST, and we split every DST in 3 stages of preparation, actual MDT, and post-MDT write-up. So when we were measuring it during the pilot, we understood where the time savings coming up and what we need to focus on. But it wasn't only about time, it was also about the quality. We tracked all other benefits. We looked at the quality of the output. We spoke with clinicians about how they find their roles and how they find the tool. And it was really interesting to see that on average, during the first 8 weeks of pilot, we saved around 112 minutes per DST. But we could see the trend that the saving of time actually grow with the confidence of the team. And by the end, it was around 3 hours per DST saved. So really significant difference. Later, all those savings translated into much wider picture, and based on this tracking, we were able to save around 4 work time equivalent. But the most important thing was the feedback from clinicians. They were generally happy how it's supporting their day-to-day work. And we had this really good example of during the pilot, someone in the team called sick, and normally we would cancel the DST on this day because no one was able to make themselves ready. But one of our clinicians who was taking part in the pilot, she stepped in less than 1 hour, prepared herself for DST. And when she completed it, she actually was complimented by a family member how well she was prepared and how engaged she was during it. So it just shows us that definitely there is potential and we need to work on it more.
100%. Thank you for taking us through that. And also amazing to see your dashboard there, that level of detail in terms of the measuring the impacts and making it tangible is super impressive. Matilda, I would come to you. So the pilot obviously delivered some very positive results as we heard. And I guess why did BMX decide to go kind of back to the drawing board in terms of the product rather than carry on with what you had at that point?
So I think the pilot proved, this data alone proves that there was like something in this. We knew that there was impact with the product, but we also knew that what we'd implemented in the pilot were hacky workarounds at best, and this was not where we wanted the product to be. From a product perspective, there were 2 things that were really clear. One, we had to go beyond ambient scribe technology. That is, pretty basic at this point. And secondly, we had to go beyond what was a pretty early stage report builder functionality. What we knew was that whatever we built had to be able to hold huge amounts of evidence. It had to be able to cope with those hundreds and hundreds of pages. It had to be able to guide a clinician through that workflow, stage by stage. It had to be so easy to use. It had to capture the MDT flawlessly and capture those conflicts of professional opinion really clearly. And it needs to be able to generate something that just held up to the complexity of the kinds of conversations and decisions that are being made in continuing healthcare. But rather than take you through the details, I'm going to attempt, in spite of the tech problems we had this morning, to do a very quick live demo. So let's move across to here. Okay, so the way that you would start is kind of in order for a clinician to gather together all of the evidence prior to going into an MDT, they would upload a bunch of their files, or they might pull them directly from whatever case management system you are using. Once you've uploaded those files, as you can see, we've got quite a lot of chunky files there, the model will be able to detect, based on what is normally in a continuing healthcare assessment and based on the evidence that's already been uploaded, are we missing anything key? And we know that the evidence gathering stage is incredibly painful and manual when you're having to chase down documents. So what we can do here is we know that we need a neurology specialist review. So we can create a request. And what this is going to do is it will email, it can text, it can even call your GP. So you'll send the request out, and as you can see, you can track what is happening there. Unfortunately, we've got a situation which probably isn't too uncommon, where the GP would prefer to discuss by the phone. So that's okay, we can be a little bit more aggressive, we can trigger a call. And lo and behold, we have got the information that we need off the back of that. So a clinician can view the attachment, download it, check that they are comfortable with it before they then add it into the plan. So let's add that into the plan, and let's maybe skip this other one because perhaps that's not relevant. We're then going to go to build the pre-read, and what it's going to do here is pull together all of those sorts of information and summarize it in an easy to navigate format. So the domains that you'll see on the left-hand side should be familiar to everyone in the room, but the key here is that a clinician can move through them very easily, and every piece of information is traceable, and we know this is incredibly important for the DST process. So as you can see, references will be provided for every piece of information, down to the page number, the document, the exact quote that kind of came from. So everything is traceable. A clinician can come in and edit this at any point. So I can type, as you can see I'm doing there. So I can make edits, one. I can also ask the AI to help me out with it, to make things clearer, more concise, just to help speed up the editing process. But the key thing I want to call out here is once all of this has been generated, a clinician can have this in front of them while they are conducting the MDT. And this frees them up to really focus on the conversation that's being had in front of them, to navigate easily between the sections as needed. And at the same time, they will be recording via Beam Notes the MDT itself. So let's pretend we've recorded the MDT, and afterwards we want to add that in. So we're going to click Add MDT Meeting. You'll then click Create the final DST, and it's going to regenerate based on that very rich MDT discussion, and it will pull out information from different colleagues, and it will put them into the relevant sections. The key thing I want to call out here is this is never intended to replace clinical judgment. It is really, really critical that stays with the experts in the room. So yes, there is the MDT level piece. You can select that and choose what is the relevant level, and you can add in those details yourself. And at the end of all of this, you can either download it as a docx in the format of the national template, or you can push it directly into whatever case management system you are using. I'm going to pause there because I'm aware that we are probably approaching time, but I wanted to give you a flavour of what our technology looks like. And the other thing I want to say is what you've seen just here can apply to any complex workflow. So we started with DSTs because it is one of the most complex workflows, but this same technology is being deployed in hospital discharge, mental health, ADHD assessments, really anything that is mental health, community, complex care. That is really where we are focused on.
Thanks so much for talking us through. Yeah, I'm very conscious of time, so I want to maybe just move to kind of final thoughts before we maybe have a little bit time for questions. So, Marta, coming to you, I guess, what would be sort of the last thought to leaders, clinicians, people working in this space in this room? If the technology is only sort of part of the solution, what else is part of that really makes us work and gets us the impacts that you see?
Okay. So we started slow and we grow. We started with one template. We now have around 20 different use cases with 170 staff using it. But I think what is the most important for everyone in the room is to understand that this wasn't ever about technology, this wasn't ever about AI, and I have a lot of conversation about it because people get excited about AI, and I know why, but it was about leadership, it was about culture change and how we implemented this change into the service with people rather than to them, how we engaged clinicians, measured the impact, and were able to share our model with others. And I think what is also important is that we never stopped at the pilot. The actual work started when business as usual came, because now the focus is not on recognizing the tool, it's about building through leadership this change and making sure that this change is sustainable and embedded to our work. And I think that's the most important.
Yeah, and I think I can speak for myself, Matilda, when I say that you've done an incredible job of doing that, in that change management at Hampshire and Wight. Matilda, any final points from you before we move to...
I'll be very brief. I think just two things from me. The best technology for this kind of complex work won't come off the shelf. And it really comes from ICBs and trusts and social care, local government, partnering with technology vendors. So I would just encourage you, if you are a buyer in this room or you want to use this type of technology, be demanding and be curious and seek to partner with those kinds of organisations who will go that mile. It is very, very important to creating something that actually works for you in your kind of day-to-day clinical lives. And the second piece, as Marta has touched upon, technology is great. You know, I work for a tech company, but if you don't have the leadership, if you don't do the change management behind it, that shiny piece of technology will sit on the shelf unused. And that's before we talk about the kind of lack of ROI you'll get from that. So it is so important to take everyone on that journey, from your clinicians to your team managers to your senior leaders. They have to be bought in at each stage. They have to feel that they are co-designing and co-building this technology with you. And so I would encourage you, when you're also looking to partner with suppliers, is think about who is going to partner with you on that change management journey rather than sell you a license and walk away. That is what will enable you to get the most out of this technology and ultimately enable it to be an enabler. It is there to support your staff, not to replace them. And I just want to echo what Theo has said in terms of just giving a really genuine, huge thank you to the likes of Marta. She is very bold, she is innovative, and she is a real force for change in this space. So do come up to Marta afterwards. I know she was feeling embarrassed about me saying that, but we wouldn't have been able to build this technology without her. We're now working with about, I think, 14 ICBs by my latest count in continuing healthcare and a wider range of trusts as well. So we'd love to have a conversation. But really, the star of the show here is Marta.
Okay, we got time for maybe one or two questions, so I'm looking at the...
Well, I think let's read out.
I'll read out a couple of things. So yeah, one here, AI is complementary tool, not replacement for clinical judgment. I think hopefully you heard from that in terms of that change manager piece, but that is absolutely core to, I guess, how we build products at Beam, but then also to how those products can be implemented with teams. It's not there to replace clinical judgment. It's there as a summarization tool to help get you to that first draft quicker, but it's not going to infer any like clinical analysis or judgment. You got some questions here around, has it had an impact on the number of nurse assessors in the team? Should I put you the answer is?
It hasn't changed the numbers, and I think we all know what's the position across ICBs, but what it allows us to do is our nurses assessors don't have to log in the evening to prepare for DST. They can work their core hours.
The huge impact we often bear. Cool, I think that's probably all we have time for. So thank you all so much for joining.
Thank you.
Thank you.